Usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like engineering.
Exactly. Like if you break your arm, the x-ray shows a jagged white line, and the doctor just points at it. It's broken or it's not broken. It's a very clean, visible, perfectly categorized problem.
Yeah, we find that binary really comforting, but human biology rarely respects perfectly clean lines,
No, it really doesn't.
especially when you step into the world of human reproduction.
Right, and that is exactly what we're exploring today. Because in obstetrics and gynecology, that metaphorical x-ray machine is, well, it's fundamentally broken. You're dealing with a diagnostic landscape that is entirely murky.
Because the system is literally designed to constantly change.
Exactly. It rewrites its own rules every single month, and then it completely remodels itself over a 9-month pregnancy. Okay, let's unpack this. Welcome to the deep dive. Our mission today is to take a stack of clinical cases from the textbook Obstetrics and Gynaecology, Clinical Cases Uncovered, and distill them down.
Into a really high-yield clinical review.
Yeah. We are looking at everything from foundational anatomy to extreme obstetric emergencies. So if you're a medical student, a young professional on the wards, or just someone intensely curious about the actual mechanics of the female body, this deep dive is tailored specifically for you.
We're going to decode the medical jargon and focus on how things actually work in practice.
Right. And to do that detective work effectively, you have to establish the baseline first.
You really do. I mean, you cannot spot a pathology if you don't understand the blueprint of the machine on a normal day.
So where do we start?
Well, a great place to start is the lower genital tract, specifically the cervix, because it demonstrates just how dynamic this whole system is.
Yeah, the sources focus really heavily on this one area of the cervix called the squamocolumnar junction, or the SCJ. And I always thought of the cervix as just this static doorway.
Most people do.
But the text describes this junction almost like a cellular battleground.
That is actually a very accurate way to visualize it. So deep inside the cervical canal, you have columnar epithelium. These are tall, delicate cells.
Okay.
But the outer vaginal environment is naturally acidic, right? Which is a vital defense mechanism against bacteria.
Makes sense.
But when those delicate inner columnar cells are exposed to that harsh acid, they're basically forced to physically adapt. They transform into tougher, flat, squamous cells.
So the body is actively changing its own cellular structure just to survive its own environment.
Exactly. It's a process called squamous metaplasia.
But the text mentions this creates a massive vulnerability, right?
It does. Because these cells are in this constant state of rapid turnover and transformation, this specific junction becomes incredibly susceptible to viral interference.
Like HPV?
Yes. This is precisely where abnormal precancerous cell changes tend to originate. It's the exact bullseye we're looking at during cervical screening.
That blew my mind. The normal protective mechanism against acid essentially opens the door for cellular mutations.
So it's a wild trade-off.
And that theme of, dynamic ongoing change, it's even more obvious when you look at the menstrual cycle. It's entirely managed by the brain.
Right, specifically the hypothalamic pituitary axis.
Yeah. And from what I understand, follicle stimulating hormone, or FSH, acts like an accelerator, getting an egg ready in the ovary. And then there's this massive wave of luteinizing hormone, LH.
Which acts as the trigger for ovulation.
Right.
And following ovulation, the body is flush with estrogen and progesterone, basically anticipating a pregnancy.
But if that doesn't happen,
then those hormone levels plummet, and that sudden withdrawal of hormonal support is what causes the structural collapse and shedding of the uterine lining.
menstrual period.
Exactly. But if a fertilized egg does implant, the entire physiological operating system of the mother undergoes a radical remodeling.
I was reading the numbers on this remodeling, and they are staggering. A pregnant woman's blood volume increases by 40 to 50%.
It's a massive expansion.
She is basically running a 9-month physiological marathon, building an entirely new cardiovascular infrastructure to support the fetus. But there was one adaptation that genuinely confused me.
Oh, which one?
The text says that to prepare for delivery, the mother's body fundamentally alters its own clotting cascade. It enters a hypercoagulable state.
Yes, it does. The body deliberately ramps up the production of fibrinogen, which helps form clots.
Okay.
And simultaneously, it decreases fibrinolytic activity.
Which is the mechanism that breaks clots down, right?
Precisely.
But wait, if you have 50% more blood pumping through the system and you make that blood thicker and harder to break down, aren't you just creating a massive blood clot risk for the entire 9 months?
If we connect this to the bigger picture, you are identifying a major evolutionary trade-off.
Okay, how so?
By thickening the blood, the body is trying to prevent catastrophic fatal bleeding during childbirth. But the cost of that insurance policy is a significantly elevated risk of venous thromboembolism.
Dangerous blood clots.
Right. Throughout the entire pregnancy and well into the postpartum period, the normal physiological adaptations of pregnancy actually mimic disease states.
Wow. Which perfectly explains the warning about supine hypotension. The sources are absolutely adamant that pregnant women shouldn't lie flat on their backs.
Yeah, and it's a purely mechanical plumbing issue.
Because the heavy pregnant uterus literally squashes down on the inferior vena cava, right? The main vein bringing blood back to the mother's heart.
Exactly. The physical compression chokes off the venous return. So if less blood gets to the mother's heart, less blood is pumped out.
Her blood pressure bottoms out.
Yes. And crucially, the blood flow to the fetus drops.
This mechanical shift is a perfect example of why the baseline matters so much. If you don't know the baseline, you can't be a good detective in the clinic.
You really can't.
So let's say you're the clinician walking into an examination room.
Yeah.
You have a non-pregnant patient presenting with a gynecological issue. The text is very strict about the initial approach, like before you even pick up a tool.
Oh, absolutely. The emphasis is heavily on trust and safety, aligning with general medical council guidelines. You must obtain explicit consent, and you must always offer a chaperone.
Always.
Always. And once you move to the physical examination, the tools you choose depend entirely on the anatomy you're trying to assess.
Right, let's talk about the speculums. You have the Cusco speculum, which looks a bit like a duckbill. That one is designed to open the vaginal canal so you can look directly at the cervix for a smear test.
Correct.
But if a patient is complaining of a prolapse, say, feeling like something is physically falling out, you wouldn't use that. You'd use a Sims speculum.
Right, because a Sims speculum is shaped more like a right-angle retractor.
How does that help with the prolapse?
It allows the clinician to hold back one wall of the vagina at a time while asking the patient to bear down. This lets you see exactly which structure is prolapsing.
Oh, I see.
Yeah, is it the bladder pushing into the front wall, creating a cysticle? Or is it the bowel pushing into the back wall, creating a recticle?
And you can't treat a mechanical collapse without knowing which wall has failed.
Exactly. Symptom management heavily depends on how much the issue impacts the patient's daily living activities.
Let's apply this to some actual presentations. Take early pregnancy bleeding. A 24-year-old comes in with a positive pregnancy test, and she's bleeding. As a clinician, you're trying to differentiate between a threatened miscarriage and a life-threatening ectopic pregnancy.
A very common, very tense scenario.
The text relies heavily on tracking something called beta-HCG. What exactly is that measuring?
Beta-HCG is the hormone produced by the developing placenta. And in a healthy, viable pregnancy, the levels of this hormone should double roughly every 48 hours.
Like a biological signal that the pregnancy is growing.
Right. So if you draw her blood over 2 days and that hormone level is rising sluggishly or dropping, it means the tissue is failing.
And you combine that with a physical exam, right? If her cervix is open or ballooning, the miscarriage is already happening.
Yes. But if she has severe localized pain and erratic beta-HCG levels, you have to hunt for an ectopic pregnancy.
Which usually happens in the fallopian tube.
Right. And if that tube bursts, it is a surgical emergency.
Now, the differential diagnosis changes completely if the patient is not pregnant and presents with acute pelvic or vulval pain, right?
Completely. We have to consider an ascending infection like pelvic inflammatory disease.
EID.
Yeah, which is often caused by untreated chlamydia or gonorrhea tracking up into the uterus and tubes. Or we look at the ovaries. You could have a cyst that has physically twisted on its own blood supply.
A torsion, like a garden hose getting kinked, cutting off oxygen to the ovary.
Exactly.
And then there's the Bartholin's abscess, which is just a fascinating piece of anatomy. The Bartholin's glands sit near the vaginal opening to provide lubrication, right?
Yes.
So if the tiny duct gets blocked, the fluid backs up into a cyst. And if bacteria get in there, it becomes this incredibly painful abscess. But the treatment isn't just like popping it with a scalpel, is it?
No, because if you make a simple incision, the tissue edges will quickly heal and seal right back together. The duct remains blocked, the fluid backs up again, and the abscess returns.
So to fix the plumbing permanently, the text says you have to do a procedure called marsupialization.
It's a great word.
It is. You make the incision,
Mm-hmm.
and then you stitch the edges of the cyst wall to the surrounding outer skin. You're literally creating a permanent little open pouch, like a kangaroo, so the gland can continuously drain and function normally.
It's a highly effective structural fix.
Brilliant surgical engineering.
It is, but here's where it gets really interesting. The most critical skill for a clinician isn't just fixing structures, it's pattern recognition, particularly regarding age.
Oh, definitely. A 25-year-old presenting with a pelvic mass is an entirely different clinical scenario than a 57-year-old presenting with the exact same symptom.
Night and day. In the younger patient, you're thinking benign cyst or ectopic pregnancy. But in a postmenopausal woman, a pelvic mass combined with vague symptoms like abdominal bloating should sound a massive alarm for ovarian cancer.
So age completely rewires the diagnostic algorithm.
It has to. For that older demographic, we immediately test the blood for CA-125, which is a protein marker often shed by ovarian tumors.
And then use ultrasound features to calculate a risk of malignancy index.
Exactly.
We see that same vital shift with abnormal bleeding. Heavy periods are pretty common in younger women, though you still have to check for physical blockages like fibroids.
Right.
But once a woman has gone through menopause, any postmenopausal bleeding PMB is considered endometrial cancer until proven otherwise.
It's a massive red flag.
The text states you have to use a transvaginal ultrasound to measure the physical thickness of the endometrial lining. Why is the thickness the giveaway?
Because cancer essentially involves uncontrolled cellular growth. It builds tissue. So if the ultrasound shows a thickened uterine lining long after it should have become thin and dormant, that's highly suspicious.
And then you have to take a biopsy of that tissue to see exactly what those cells are doing.
Precisely.
Which actually takes us right back to our anatomy discussion about the cervix and abnormal smears. When that vulnerable squamous-columnar junction gets infected with high-risk HPV, it can trigger cervical intraepithelial neoplasia, or CIN.
Precancerous cellular changes.
Yeah. So if a biopsy confirms high-grade CIN, how do you get rid of it without destroying the whole cervix?
The standard treatment is LLETZ.
Large loop excision of the transformation zone.
Right. A thin wire loop carrying an electrical current is used to precisely shave away that entire vulnerable junction.
Like scooping the bad spot out of an apple with a hot wire.
That's a good way to picture it. It removes the pathology, but preserves the structural integrity of the cervix.
Which is absolutely vital if that patient wants to carry a pregnancy in the future.
And pregnancy is where the clinical complexity reaches its absolute peak. Transitioning into obstetrics means every single decision you make impacts two interconnected patients simultaneously.
The ultimate stress test.
Yep.
Antenatal care seems heavily focused on mapping out risk as early as possible. Take down syndrome screening. The text mentions looking at neutral translucency on a first trimester ultrasound. That's measuring fluid at the back of the fetus's neck, right?
Yes, because certain chromosomal conditions affect lymphatic drainage, causing fluid to pool there.
And we combine that ultrasound measurement with maternal blood markers like PPPA, a protein produced by the placenta.
Right, and this combined data gives the parents a risk probability.
But probability isn't a diagnosis.
Oh, it's not.
If they want a definitive yes or no, they have to undergo diagnostic tests like amniocentesis or chorionic villus sampling, where a needle is used to physically take cells from the amniotic fluid or the placenta for genetic testing.
And that requires a heavy conversation because poking into that environment carries a roughly 1% risk of triggering a miscarriage.
Wow. And speaking of the placenta, it really is the central organ in obstetrics, isn't it? It drives so many of the maternal complications we see.
It really does. Gestational diabetes is a perfect example.
I found this part fascinating. The sources explain that as the pregnancy progresses, the placenta acts like an endocrine organ, pumping out massive amounts of anti-insulin hormones.
Yes.
It's almost like the placenta is staging a hostile corporate takeover of the mother's pancreas. Why would it do that?
Because the placenta is fiercely prioritizing the fetus. By creating maternal insulin resistance, it ensures that glucose stays circulating in the mother's bloodstream longer.
Allowing more sugar to cross over to feed the growing baby.
Exactly.
So if a diabetic mother can't inject enough insulin to overcome this placental blockade, her blood sugar spikes. That floods the fetus with sugar, leading to a massive baby-fetal macrosomia.
Which sets the stage for a nightmare delivery.
Yeah, managing labor requires immense vigilance. Clinicians use a tool called a partogram, right?
Yes, a partogram is a visual graph plotting the progress of labor over time. We track the dilation of the cervix and the physical descent of the fetal head.
And if the progression crosses an action line on the graph,
Yeah.
it visually flags that labor is stalling.
Right. But if labor hasn't even started and the baby needs to come out, you assess the cervix using the Bishop score.
Right. This score decides if induction will actually work. You're looking for a cervix that feels soft, like your lips, rather than firm, like the tip of your nose.
Exactly. If the score is low, the cervix is essentially an unripe fruit, and you have to use prostaglandins to chemically soften it first.
But induction also introduces unique risks, especially if a woman is attempting a vaginal birth after cesarean or VBAC.
Yes. If we use a synthetic hormone like oxytocin to force strong uterine contractions, the mechanical stress on the old C-section scar can cause the uterus to physically rupture.
The sheer mechanical force is terrifying. But sometimes the danger isn't mechanical, it's systemic.
Like preeclampsia.
Yes, described as one of the most insidious obstetric emergencies. It hits after 24 weeks, defined by surging blood pressure and protein leaking into the urine.
The proteinuria happens because the high maternal blood pressure is physically damaging the filtration system in the kidneys.
And the disease can rapidly escalate to eclampsia, which is defined by maternal seizures, right?
Yes. And the only definitive cure is to remove the source of the problem by delivering the placenta.
But as she's crashing, you have to keep her alive while you prep for delivery. The text details using IV hydrolysine to rapidly dilate her blood vessels and lower the pressure. But then you give intravenous magnesium sulfate.
Yes.
How does magnesium actually stop a seizure?
Well, magnesium acts as a powerful central nervous system depressant. It essentially competes with calcium in the brain cells, slowing down the electrical impulses and significantly raising the threshold required for a seizure to trigger.
Wow. Chemical crowd control for the brain.
That's a great way to put it.
The other massive emergency category is hemorrhage. Antepartum before birth and postpartum after birth.
Right.
For antepartum hemorrhage or APH, the symptoms tell you exactly what is failing. Like if a patient comes in with painless bright red bleeding, you suspect placenta previa.
Yes, meaning the placenta has implanted too low and is covering the cervical doorway.
And there's a cardinal rule here.
Absolute prohibition of digital vaginal exams.
Because if a clinician blindly inserts a finger to check the cervix,
They will punch a hole directly through the highly vascular placenta, causing catastrophic immediate bleeding. You must use ultrasound to locate it safely.
the darker side of that coin is a placental abruption.
Yes.
The patient presents with sudden, severe abdominal pain, dark bleeding, and a uterus that feels woody hard.
The placenta is prematurely tearing away from the uterine wall. Blood is pooling behind it, the baby is losing oxygen, and the mother is bleeding out internally.
It's terrifying. And bleeding risks don't stop at delivery. Postpartum hemorrhage, defined as losing more than 500 milliliters of blood, is most commonly caused by uterine atony.
Atony meaning the muscle lacks tone.
Right, because after the placenta detaches, it leaves a massive raw wound. The uterus is supposed to violently cramp down, acting like a biological tourniquet to pinch off those bleeding vessels.
But if it just stays relaxed and floppy, the patient bleeds out in minutes.
So if you're the clinician in a room when a massive hemorrhage or abruption hits, how do you even prioritize the chaos? You have a dying mother and a suffocating fetus.
This raises an important question, and the priority is the bedrock of emergency medicine, maternal ABCs.
Airway, breathing, circulation.
Exactly. The clinical reality is that fetal survival is entirely dependent on maternal stability. You cannot save a fetus inside a mother who has no circulating blood volume.
So you hyperfocus on the mother. You get 2 large-bore IVs into her arms, rapidly pumping in fluids and cross-matched blood. You give her oxygen,
And for that floppy uterus, the text says you start bimanual compression.
literally putting a fist inside the vagina and a hand on her abdomen to physically sandwich and crush the uterus to stop the bleeding while you give drugs to force it to cramp.
And if conservative measures fail, surgery is required. We might use balloon tamponade.
Inflating a silicone balloon inside the uterus to put direct physical pressure against the bleeding vessels.
Right. Or we place a B-Lynch suture.
What's that?
It involves wrapping a heavy surgical thread completely around the outside of the uterus, pulling it tight like a pair of suspenders to forcefully fold it shut.
Yeah, so the plumbing solutions are actually pretty wild. We've covered the major traumas, but the sources emphasize 2 other conditions that require immense patience rather than surgical speed: PP-ROM and hyperemesis.
PP-PROM is preterm, pre-labor rupture of membranes. The amniotic sac breaks before 37 weeks.
And unless there's an infection, the management is conservative, right?
Yes, we administer corticosteroids to cross the placenta and accelerate the production of surfactant in the fetal lungs so they can breathe if born early. We give antibiotics to hold off infection, and we wait.
And then there's hyperemesis gravidarum, which is extreme, relentless vomiting in early pregnancy. It's not just morning sickness. It is severe dehydration.
Very severe.
You have to aggressively rehydrate the patient through an IV, but the text gives a stark warning. Never use 5% dextrose fluids initially. Why is sugar water dangerous?
Because metabolizing that IV glucose rapidly consumes the body's remaining stores of thiamine or vitamin B1.
Oh, wow.
Yeah, in a starving, vomiting patient, thiamine is already critically low. Depleting it further can precipitate Wernicke's encephalopathy, which is acute, irreversible brain damage.
From an IV bag.
Yes. We must use normal, saline, and aggressive anti-nausea medications instead.
It is incredible how one wrong bag of IV fluid can cause a neurological collapse. Mastering obstetrics and gynecology really is about seeing the entire interconnected web of human physiology.
It absolutely is. You have to recognize when a symptom is a necessary part of the biological marathon and when the machinery is actually breaking down.
Yeah.
So let's put that to the test for you, the listener.
No. Pop quiz.
Just a quick clinical exercise to test your new knowledge. Imagine you are the doctor on the ward right now. A 39-year-old patient at 37 weeks gestation arrives by ambulance. She has sudden, constant, severe abdominal pain. Her uterus feels completely rigid, woody hard. She has dark vaginal bleeding, and the monitors show her blood pressure is dropping rapidly.
Right.
Based on the plumbing and pressure we've discussed, what is your primary differential diagnosis, and what is your immediate first step?
Okay, let's reason this out for everyone. She has dark bleeding and that classic woody hard uterus. It's not painless, so it isn't placenta previa.
Right.
The severe pain means the placenta is physically tearing away from the wall. That's a placental abruption.
Spot on.
And her blood pressure is tanking, which means she is going into shock. So my first move isn't listening to the fetal heartbeat. It is maternal ABCs. Secure her airway and get 2 large-bore IVs pouring fluid into her arms to restore her circulation.
Perfect. You resuscitate the mother to save the baby. You've successfully navigated the acute crisis.
Nice.
But I want to leave you with a final thought that extends far beyond the delivery room. We noted earlier that pregnancy forces a massive increase in cardiac output, severe insulin resistance, and a hypercoagulable state.
Right, it's an extreme systemic stress test.
Pushing the body's vascular and metabolic limits to the absolute brink. So consider this. If the body's hidden weaknesses are exposed under the stress of this 9-month marathon, could a severe pregnancy complication like preeclampsia or gestational diabetes actually serve as a crystal ball?
Oh, wow.
Could these obstetric emergencies be giving us a vital, decades-early warning about a woman's specific individualized risk for cardiovascular disease or stroke in her old age?
That is a phenomenal concept. The biological blueprint cracking under stress today, revealing the exact locations where the foundation might crumble 30 years from now.
It's definitely something to think about.
That is something to keep in mind the next time you find yourself looking past the simple X-ray, trying to decode the murky, brilliant mechanics of the human body. Catch you next time on The Deep Dive.